Welcome to the Metabolic Link, a medical and science-focused podcast that explores the common thread of metabolism in health and disease. This is where science meets society. Welcome to the Metabolic Link podcast. I'm your host, Victoria Field, alongside my fellow amazing co-host, Dr. Dominic D'Agostino, Dr. Angela Poff. Hey guys, so good to see you today.
Hey,
good to see you.
Good morning.
Yeah, and thank you all for joining us, whether you're joining on YouTube or listening on a major podcast player. You can do both. So if you just want to listen on the go, you can certainly do that. But today's episode, we're going to be diving into a journal club, which is a really fun episode, really fun discussion around a couple of papers actually that we've got today, where we just dig in and discuss the science and have a good time. And so it's really helpful for us to know if you are liking these kinds of episodes. Leave us a comment, leave us a review. It's really helpful because we try to put these journal clubs in between, interviews with experts, presentations from our conference, Metabolic Health Summit. And it's good for us to have feedback on what you guys want to see more of. So we really appreciate, also, I want to mention you supporting our sponsors. Our sponsors make this content possible. So thank you so much for listening to the ads in this episode and engaging with our partners as well. And all the partners that we put out into the world via the Metabolic Link, we believe in. So we appreciate you supporting our friends in this field because they make the Metabolic Link possible. And if you want to get, though, ad-free, exclusive, private episodes, things that we don't even release to the public, you can via our medical education platform, the Metabolic Initiative. Just go to membership.metabolicinitiative.com if you want to check out exclusive podcast episodes that are ad-free. So without further ado, though, we've got some really exciting papers to jump into today, really interesting topics. Angela's going to be taking us through a paper titled Exposure to Sugar Rationing in the First 1,000 Days of Life Protected Against Chronic Disease. This is going to be a really interesting conversation that I'm really looking forward to. And then we've also got one around glioblastoma titled Clinical Research Framework Proposal for Ketogenic Metabolic Therapy in Glioblastoma that Dom is going to lead us through. And it's going to be a really fascinating discussion. So hang on tight. Angela's going to kick this off, though, with our sugar rationing paper. And I'll toss the baton over to you, Angela, to get us started.
Thanks. Sounds good. Okay, this is a really cool paper. It came out in October of 2024. It was published in the journal Science, so really impactful journal. And as Victoria said, it's titled Exposure to Sugar Rationing in the First 1,000 Days of Life Protected Against Chronic Disease. The paper here with me, because I still print things, because apparently I'm old like that, but that's okay.
So do I. We're in the same boat.
I know. I just retain things a lot better when I can actually
highlighting, right?
Yeah. Yes, I gotta highlight, gotta make notes. Okay, so this paper, really the goal of this study was to see if sugar exposure, or alternatively sugar restriction, in utero and in early childhood affects humans in the same way that it's pretty clearly established to do so in animal model systems. So there's quite a lot of data suggesting this causal relationship between excessive sugar intake in early life in rodents and poor metabolic health over the lifetime of the animal. And in particular, we think that this would probably translate to similar effects in humans, and in particular things like an increased risk of type 2 diabetes or hypertension that's been observed. But as you can imagine, it's not really easy to, or potentially ethical in some cases, to pull off this kind of study, especially not as a controlled trial that could really test a causal relationship in humans. So the authors did something really interesting. They turned instead back to a period of history that kind of naturally set up this interesting quasi-experimental condition, and that they were able to use to get this really valuable insight into how this phenomenon might actually also occur in humans. So back during World War II, the UK began rationing sugar. It was part of its wartime food rationing program. This began in January of 1940. It lasted until September of 1953. And during the rationing period, the sugar allowance for everyone, including pregnant women and children, was comparable to today's dietary guidelines, so that it was less than 40 grams of sugar per day for adults and less than 15 grams of sugar a day for children. And children under 2 were assumed to really have little to no sugar offerings available to them, and that's also what's currently recommended. So, the rationing system was overseen by the Ministry of Food, and everyone was given a ration book with coupons, and then these coupons were required to purchase goods that were rationed at the time. So, this rationing period ended in September 1953, and pretty much immediately after, people began eating about twice as much sugar as they did during the rationing period. So, they went from consuming an average of 41 grams of sugar per day for adults during the rationing period to about 80 grams within a year's time. So, in order to see the effects of this early life sugar exposure on type 2 diabetes and hypertension, which is high blood pressure, they compared adults who were conceived shortly before rationing ended, those that would have probably had this lower early life sugar intake, to those who were conceived shortly after, who then had about twice the amount of sugar exposure in their early life. And one interesting thing they said is that sugar consumption doubled in adults after rationing ended, and that heightened level of sugar consumption was maintained across their lifespan, so into their 6th decade of life. So once people kind of returned to eating higher amounts of sugar, they kind of stuck with it, basically. Importantly, calorie consumption did also increase after sugar rationing ended, but the data suggests that most of that increase in calories was in fact due specifically to that increase in sugar consumption. So they did also ration other foods during the period, but the author said that the consumption of foods and nutrients other than sugar didn't show nearly the same kind of major change after rationing ended. So things like cheese and milk, fresh fruit and vegetables, and even cereals, consumption of those products didn't really change that much. It was an increase in sugar that really dramatically happened after the rationing period ended. They said there was also a minor decrease in fish consumption and a gradual increase in meat consumption after the rationing period ended, but overall protein intake remained pretty much steady, and food affordability didn't change very much either before versus after the rationing period. So this is the authors kind of looking to understand limitations to the data set that they're using to make these to get these studies done. So, okay, overall, there was this quick and sharp response in consumption and sales of sugar and sweets that happened pretty much immediately after de-rationing, and that was not observed in other food groups. So this kind of strengthens the research design that this is a valid data set to use for what they're trying to use it for. Okay, so the study population included over 60,000 participants that were born between October 1951 and March 1956. And these individuals were then aged 51 to 66 when they were surveyed later to see what kind of health problems they did or didn't have. Okay, so they grouped the individuals based on when they were conceived, and the two big groups were just kind of the pre and post, if you were conceived before or after rationing had ended. So adults conceived in the 1,000 days before September 1953, which is when that rationing ended, were classified as rationed, and there were about 38,000 of them in the data set. And then they compared those to those conceived after rationing ended, who were classified as never rationed, and they had about 22,000 people in that sample. They also looked more closely at the data and they separated out the level of rationing exposure. So, for example, people who were exposed to sugar rationing in utero but not after birth, or maybe they were exposed to sugar rationing in utero plus the first year after birth but not beyond that, or those that were in utero all the way to the 2nd year of life. So, overall, they found that risk of disease, and in particular type 2 diabetes and hypertension, increased with age for everyone, as expected, but it increased faster in adults who experienced little or no sugar rationing. And interestingly, they saw kind of like a dose-dependent response, such that the risk of type 2 diabetes or hypertension decreased with the duration of exposure to sugar rationing increasing. So more sugar rationing was more protective than less sugar rationing. And when they compared to the group of individuals that were never sugar rationed, those who had been exposed to sugar rationing only when they were in utero had about a 15% lower risk of developing type 2 diabetes. And for those who were exposed to rationing longer, so in utero plus like the following 19 months of life in that postnatal period, they saw a 38% reduction in the risk of type 2 diabetes. They saw a similar pattern for hypertension, but the risk reduction was smaller. So those who experienced sugar rationing in utero only saw about a 6% reduction in risk of hypertension compared to those with no rationing. But those who were rationed for at least 19 months saw a 21% reduced risk. And they did a lot of comparing the different groups and risk ratios, and what they kind of concluded was that in utero exposure to sugar rationing alone explained about a third of the total reduction in type 2 diabetes and hypertension risk that was seen. So even those babies that were only exposed to sugar rationing through their mom, when their mom was pregnant with them, that was about a third of the benefit came from that alone. And they also found that the benefits were more prominent in groups when sugar rationing went beyond 6 months of life. And this probably has something to do with the fact that 6 months is around that age when babies start introducing foods aside from breast milk and formula. And interestingly, so for those who were sugar rationed for more than the first year postnatal, the risk reduction for type 2 diabetes was significantly larger for women than it was for men. It was present in both, but more impactful in women. And those individuals who experienced sugar rationing in utero or early childhood who still went on to develop type 2 diabetes or hypertension, they did so later in life. So exposure to sugar rationing in that early period delayed the onset of those metabolic diseases. And rationing in the in utero period and for at least 1 year following birth delayed type 2 diabetes onset by about 4 years and hypertension onset by about 2 years, which is pretty cool. So this data really agrees with a large preclinical literature database that shows that excessive sugar exposure in utero and in the early postnatal period can really have lifelong adverse consequences. We don't really understand exactly why yet, but there's a few different theories. One, the fetal origins hypothesis, where basically it proposes that nutritional exposure during the middle to late stages of pregnancy creates changes in these really complicated physiological programming that's taking place in the baby at that time in such a way that it can really result in lifelong physiological and metabolic consequences that can either be protective or detrimental to health, even way later in life. We're talking about older adults. And it's also thought that early life exposure to excess sugar can intensify a lifelong preference for sweetness. And they think that infancy and toddlerhood are really critical periods for developing a preference for sweets or potentially even addiction to sweets. And of course, this is quite concerning because over 70% of foods marketed to infants and toddlers contain added sugars. And by age 2, many children in the US are already consuming the adult recommended limit of 7 teaspoons of sugar daily, but this amount triples on average by teenage years.
This episode of the Metabolic Link is brought to you by GOVA Connect, powered by Genova Diagnostics. If you're listening to this podcast, it's highly likely that you probably want to take your metabolic health to the next level, right? You want to optimize. And it's also likely that you like data, having information that will allow you to take the next step or figure out what's going on. Otherwise, it can kind of just feel like you're sort of spinning your wheels when you don't have information around sort of a health baseline, if you will. At least that's how I am. I really like to have sort of a baseline of where I'm at, work on some goals, and then know where I'm going, right? Or maybe you've felt off for a while. You've not really felt like your full self. You're super tired all the time, or you're having gut issues. Genova Connect can really help with this, and in the comfort of your own home. They make it super easy to take control of your health by offering a wide range of advanced diagnostic tests that they literally will ship to your house. You do it in the comfort of your own home, send it back, and then you have this amazing clear picture of your unique health profile that you wouldn't otherwise have, that allows you to make steps in the right direction without sort of shooting in the dark when it comes to improving your metabolic health. By using Genova Connect, you actually get accurate information on how your body functions. So they've got tests, everything from Metabolomics Plus, which we actually did a webinar with Genova Connect on this test where we kind of dove into our numbers and all of the amazing information you get just in terms of like nutrient profiles and maybe some deficiencies and things along those lines, to GI effects. That test is phenomenal. I used it actually when I was going through a bit of a tough time health wise, and it can uncover so many things about your gut microbiome and really allow for your physician and yourself to work together to come up with an actual plan versus just kind of guessing what might be going on with your gut, with, nutrient deficiencies, you name it. So highly recommend checking them out. They've really made a huge difference in my life, just not only in providing information and data, but also providing actionable items around those markers. Their test results are really comprehensive. I'm really excited to share with you that Genova Connect right now, they're offering 15% off any of their test kits when you use the code Metabolic Link at gdx.net/the Metabolic Link. Head on over to gdx.net/the Metabolic Link. Use the code Metabolic Link for 15% off their test kits. Give them a try. I know you're going to love them, and let us know what you think.
Yeah, just in conclusion, there were a lot of things that the authors kind of like mentioned as potential limitations to the study. And of course, you're looking at a data set from nearly 100 years ago, but they spent a lot of time in the discussion acknowledging and kind of talking through these limitations, which is really great. Biggest thing, of course, they mentioned the potential for differences in the cohorts other than the sugar rationing, which is of course possible, but they did really try to discuss data that minimize the confounding effect of those factors. And I thought they did a really nice job that really kind of helps support this idea that, yeah, what we're seeing in these preclinical studies is really also happening in humans. And of course, is something we need to be paying attention to.
Like urgently,
Yeah.
especially when you look at the rates of obesity in children
Yeah.
and adolescents. I think it's nearly 20% of those
Yeah.
aged between 2 and 19 years of age are dealing with obesity. Not only just obesity, non-alcoholic fatty liver disease
Yeah.
is also affecting about 10% of children in the US, which is wild when you think about it, because that,
Heartbreaking.
I mean, what's one of the biggest culprits for, fatty liver disease? Sugar.
Yeah.
And so we kind of need to take some of these statistics and, papers like this and just the clinical data so
Yeah.
far, and let's put this into action and figure this out, because
Yeah.
right now we know ultra processed foods, I think, accounts for about 73% plus of the total food supply. And it's nearly 70% of what kids are actually eating. So, and ultra processed foods being foods that likely or almost guaranteed have added sugars
Mhm.
in them.
Yeah.
It's just like we're in the middle of the of a perfect storm. And so when you
Yeah.
you go through papers like this, it's just more sort of fuel to the fire that we really need some huge changes, because even when you're pregnant with a baby, this is when all of this programming, this developmental programming kind
Mhm.
of starts. When a mom's blood sugar spikes, we know that the baby's pancreas produces more insulin, and now we're obviously understanding what some of those effects are. And granted, it's a lot of pressure on moms for sure, but these pieces of information are really, really important. And then you couple it with all the statistics of obesity and everything that plagues our children today, and it's maddening. So
Yes.
anyway,
Yeah.
there's my little 2 cents of a new mom here, if you can't tell.
Mama Bear is coming out. I love it.
Mama Bears, I'm so mad. Yeah, no, it's just, you're so much more
Yeah.
aware too when you're like a
Yes.
new mom. I was just walking through the grocery store with my son the other day, and I was just,
Yeah.
I walk through the aisle with all the cereals and crap, and you see how drawn they are to these
Yeah.
things as you're
The
walking through, and
colors and the
the
cartoons
colors and
and
the
yeah.
marketing, and it's so easy to kind of
Hmm.
go down that path in
Yeah.
our country, and there needs to be massive change that happens from the top down, hopefully soon. So, Dom, were you going to say
Yeah.
something?
Well, yeah, just like major relevance to you guys. You guys must have found this fascinating, because,
Mhm.
Yeah.
but also just from the public health perspective, from a policy perspective, but a huge relevance to physiological but metabolic reprogramming, I think, which is kind of interesting from the cancer perspective, which I'll be talking about in a little bit. But epidemiologically, this is a really interesting study. Thank you for breaking it down, Angela, the way they just mine that historical data.
Mhm.
But the idea that if you deviate from the norm and you restrict sugar in your kids, you're giving them major, massive chronic disease protection from obesity,
Yeah.
type 2 diabetes, and cardiovascular disease from the general population. So that's such a simple thing to do. The implications here need to be amplified through policy, and hopefully it does.
Absolutely.
Yeah,
Policies.
it's
Oh,
super
sorry, go ahead.
tough. I mean, it is tough. It's I think that there's a lot of misinformation even. Like I think a lot of parents, just naturally want to give their kids like juices. And I think for a very long time it's been kind of like in the general psyche that like, yeah, kids drink juice and this is healthy.
If you
Um,
grew up in the 80s, for sure you had a
yes,
free sun and you
absolute.
thought you were getting your
Oh,
daily dose of vitamin C
yes, right? It's like a health drink. And then,
along
yeah,
with your
but
50
like,
grams of sugar. Yeah.
yeah, but I think teaching parents even to read and know how to understand nutrition labels is going to be really important. I mean, parents want to do what's right by their kids. I mean, that is like I don't know any parents who don't. And it's tough, and especially, when these crappy foods are least expensive, they're shelf stable,
And
you
the
can
kids want
buy
them.
them, the kids want them,
I remember
you
I
can buy
wanted
them and
Fruit
stick them on the
Loops.
shelf.
Yeah.
Oh yeah,
I
absolutely.
wanted
Yeah. Oh
Captain
yeah, my
Crunch.
kids
Yeah.
my kids
I'd
always
be
ask
mad
for
if my
those
parents didn't
things.
get it. Yeah.
Yeah, and it's tough. But I think that's why there has to be a focus on educating parents, and when they understand the kind of impact that these things have in a very specific way, I think that you see changes. I mean, parents will do mostly anything for their children, which is great. So, just getting this information out there and supporting families to be able to afford healthy foods, I think it's going to be really important. Um, kind
Yeah.
of above all, but yeah, it's certainly a heartbreaking scenario when you think about what is happening so commonly.
Right.
Dude, the
Yeah. Well,
kids too, like, but I was just going to mention because they touch on it, the intergenerational effect. So the study
Mm,
kind of hypothesized that the metabolic benefits from sugar rationing may extend across generations,
yeah,
possibly through epigenetic, mechanisms. So, yeah, I mean, so there's intergenerational effects kind of
yeah,
potentially going on here, and I think
yeah,
that's
yeah. Oh, yeah,
really
for
important.
sure. I mean, there's so many things at play. It's really challenging, as you mentioned, Angela, like which way to go. I think though, as you touched on, Dom, policy needs to change. I mean, I do think there's a bit of a push and a shift in even food dyes and things like that. Like, unfortunately,
Mhm.
there's not a lot of regulation around some of the ingredients in these ultra processed foods as well, as particularly in the United States, right? It's like innocent until proven guilty, or guilty until
mhm,
proven innocent. So the UK is or the EU is way different when it comes to ultra processed foods, and allowing for ingredients into their food supply. You really have to go through some rigorous hoops before you can actually get a new novel ingredient into the mix. Whereas in the US, it's like, well, innocent until proven guilty. We're just gonna,
Yeah.
grass is kind of the way here, which is a bit of a loophole. And there's a lot of things in
Yeah.
our foods, not just sugar, that probably shouldn't be. The other thing to kind of think about, and this is probably going to be a little bit more on the controversial side, are the requirements and the things that we're taught. Just going through pregnancy myself recently, I really dove into the nutrition recommendations for pregnant women. And there's a minimum requirement or a minimum suggestion of 175 grams of carbohydrates per day. And there's reasonable evidence out there, and if you look at the work of Lily Nichols, who does amazing deep dives into prenatal nutrition, postnatal nutrition. If you're not familiar with her and somebody you love or yourself are pregnant, I highly recommend you checking her out. She's really an advocate of not necessarily like low carb, but whole food. And let's talk
Mhm.
about what the quality of foods people are eating. But 175 grams of carbohydrates today is pretty high, especially when you take into consideration like the rates of gestational diabetes and how that's looking in the current time. And we've just got to be really smart. I think not just with our kids and the education around that, but even pre-pregnancy of like how do we approach and get into this phase of life where we're growing humans in a way um, that takes into consideration that what we eat can potentially have lifelong effects on your children in years to come. So it's a very I know touchy subject, carbs and pregnancy and all of those things, but
Mhm.
it's interesting nonetheless when you kind of think about essential macronutrients versus non-essential and what babies really truly need in development. It's certainly not excessive sugar consumption by mom.
Right.
So yeah, just want
Yeah.
to throw that
And
tidbit out
there
there.
is likely a calorie thing too, and I don't want to kind of sidestep that if you're consuming sugar, you're likely to be consuming surplus calories,
Yeah.
in the form of sugar. And it's that calorie surplus that could be driving,
Hmm.
the obesity, type 2 diabetes, cardiovascular, which is linked to the excess sugar consumption. So sugar, the added sugar is the problem. And I think that makes things hyper
Yeah.
palatable, but that I
Yeah.
think we know that, but I think it's just important to
Yeah,
be aware.
absolutely. I think at the end of the day, like the data really shows it comes back to that added sugar. I
Yeah.
mean, because you can eat, a fair amount of carbohydrates through whole foods and especially in pregnancy, like I think that's totally fine. But yeah, I don't think anyone really needs a ton of added sugar. I think that's pretty clear.
Yeah.
So, and when you see the kind of and that's what this was looking at too, right? Like they saw that this increase in sugar that happened after the rationing. I mean, that was pretty much just added sugars for the most part
Mhm.
they
Yeah.
expect. So, um, yeah, it's a far cry when you're talking about the where the sugar is coming from and what form. And I think that yeah, pretty much the data is pretty clear that the added sugar is something that we can try to avoid at all costs.
Yep.
Yeah, I mean, maybe just briefly speak to how limiting sugar intake might be influencing metabolic regulation and developmental programming, because you guys obviously can get into the weeds a little bit more, just to kind of share that insight around what might be kind of happening here. Because obviously when mommy's blood sugar spikes, baby's pancreas produces more insulin, but it goes, a bit deeper than that. I'd love to hear your thoughts around this developmental programming piece and what's at play here when we're limiting early life sugar intake.
Well, yeah, I think just the excess sugar and energy toxicity associated with just surplus calorie consumption probably amplified more with sugar consumption because it's driving glycolysis, we know, but also insulin, IGF-1, and all the downstream pathways that are pathophysiologically linked to diseases of metabolic dysregulation. But I think they also excess consumption of sugar, especially, can drive growth factors. You have girls that are going through puberty earlier. You have type 2 diabetes in kids. And I think that the sugar is probably, I think we all agree. I think the general consensus is that the sugar is the macronutrient that's really driving the metabolic dysregulation. I don't, it's not protein, but I did see a little bit of an uptick in fat consumption on that graph, Angela. I think it
Hmm.
was like two or something. So you
Yeah.
have, so they are increasing, but I guess it maybe wasn't statistically significant, but there was definitely a signal there that went up,
Hmm.
like fat
Yeah, they
consumption
said
led
it
to
went up
sugar.
slightly. Yeah, and then
Yeah.
they talk about like, that they saw some other changes, but none of the other changes were nearly as dramatic as
Yeah.
the and I don't remember exactly what they did, but they said that they looked at the data and confirmed that about 75% of the excess calories were due to added sugar after
Mhm.
the ending of the sugar rationing.
Yeah.
Um, and it is interesting. I am not familiar with the like developmental biology that is there and what data is available to explain or potentially explain why excess sugar consumption or exposure in utero and the early childhood phase, how that translates to long-term metabolic consequences. Obviously, it seems like there's probably an epigenetic factor at play. And as you mentioned, Dom, there's even from the preclinical data, there's studies showing that these effects can actually go out multiple generations in rodents. So even mice that weren't exposed when they were in utero or their early, postnatal period, but if their moms or their grandmothers were, there's studies that have shown those consequences playing out further. And these are animals, so they're controlled diet. So even if they were never exposed and they were just on the standard rodent chow, there's still, some studies have shown that they still have an increased risk. So something's being carried on. I think they did think that, I think the authors brought up an interesting point for humans that it could be like a increased preference for sweetness. And if as a child develop the sweet tooth that people like to say, that can be really tough if it's a lifelong, preference or craving, or in some cases turns into an addiction, like phenomenon, that can really make maintaining metabolic health very difficult if you're one of those people that has like this kind of insatiable sweet tooth that is difficult to control. So, I thought that was an interesting point as well, just the developing, taste preferences in that time period seems to be a critical time period for when kids, and it's also why I think that it's thought that that's why it's a good time period to expose your kids to a lot of different foods, right? And maybe they're going to be more likely to have a diverse palate as they get older.
Yeah, or not, just, I mean, with our own child, just we've been very, very cautious in terms of like what we, exposing him to a wide variety of foods, but on the sweet front, just being mindful in that regard of
Hmm.
protein and fats kind of come first for him, and then because I just you read information around the palate develops,
Yeah.
the I guess it develops in the womb, right? So the foods that mom's eating, sweet foods, these foods I'm not, I can't even think straight because I don't sleep anymore with my baby. So, um,
It happens.
but what I'm trying to say is this develops in the womb. Their palate develops in the womb, and then once they're here and they're starting to eat solids, I think you can be really conscious around what foods you're giving them as a child. And I think if we're giving them highly sweet fruits, I think that this could be kind of controversial because there's obviously added sugars and then there's fruits. But I really
Yeah.
am
Not
curious
worried about
around,
fruits and kids,
yeah, like where's the
personally.
where's the line in terms of, exposing them to just sweetness and trying to help them gravitate to, less foods that are sweet, but also providing them with a lot of the benefits that come along with things like fruits, like
Yeah.
antioxidants and berries and stuff
Oh
like
yeah.
that.
Oh
Um,
yeah. Yeah. I
but
think personally I'm not scared of fruits
right.
for most people or children. And it is, but I do think they uh develop, their tastes differently. So my son, I would say my oldest, I feel like you're always more strict with your firstborn, and then like as the other ones come along, you're kind of like, okay, like let a little bit more
Yeah.
loose. But I will say my son is has a lot less of a sweet tooth than my daughter does. And I know that we were more strict with him too. So I'm like, I don't know, maybe that was part of it. But
Yeah, I mean, well,
but
it's
you
interesting.
we also have to be realistic too. I mean, like it is tough like for parents out there, and especially as your kid gets older. Like when you have like a baby, like a little one, I mean, it's really, pretty simple to control what they eat, and you obviously can control what your kids eat too as they grow up, but it gets more complicated. And I think that's why
Toddlers
we
are
need
debatable,
to
though.
what?
I said
What?
toddlers, that's debatable, but yeah.
Oh, yeah, no, I mean, you get to control what you offer them. You
Yeah.
cannot control what actually makes it into their
Right,
belly.
right. Or on the floor. Yeah,
Right. Yeah.
that's
Some
where I'm
days
at,
it was
right?
half of acorns, from the backyard. And you're like, what, really? Like, you wouldn't eat the
Dirt,
pot
right?
roast that I made you, but you want
Yeah,
these acorns? It's maddening, but
yeah.
that's okay. Yeah. So, but I think that's why we have to support families, and we have to be realistic too about the struggle, right? It's
Yeah.
not simple to do this, and it doesn't mean it's not worth doing. It doesn't mean it's not worth, striving to make these really important changes, but we also just need to be
Mm.
supportive and offering resources and guidance and information so people
Yeah.
can it's accessible to people, right? Like I think what sometimes this conversation can be made very like from a very kind of judgy place, and that's how it's interpreted to a lot of people. And I think it's really good to just be honest and like realistic about difficulties and limitations and what life truly looks like, especially if you have young kids, and support
Yeah.
people where they're at, and maybe
Yeah.
that's making small changes. Maybe that's a whole, if you're able to, maybe it's a whole like, you know, switch up of what your family's eating, but any step towards choosing something better is a good step to make.
And you
For
guys can
sure.
make your own baby food, right? I guess baby food
Yeah.
does have
Can.
less added sugar. Yeah, but then there's like the yogurts and stuff. And I saw something, a paper
The
that
baby food
kids,
sometimes just comes with arsenic, that's all.
yeah,
In addition to the sugar. No, yeah, you can totally, I mean, it's a full-time job, I will say.
I
Like
know, that's
what
the
I've
thing. Like
been
it is
doing the
you
last
yes,
year
you
is
can
making
make.
food from
Oh, I
scratch. It's
know.
crazy.
Oh, that
It's
it's
crazy.
wild. And that's why we need to support moms and parents in general. But like seriously, like if you're a breastfeeding mom or any mom, but really like you're talking about the amount of time that it takes out of your day to feed your infant, and especially if you're talking about having to make things from home because you want the quality to be there, which is great. And maybe you want to exclusively breastfeed your baby, which is great, but also not something you have to do at all. And there's so much
There's
time.
so much,
It
yeah.
is
Mental load.
unbelievable. And as much
Yeah.
as you
mm,
think you can conceive of it, you cannot until you're in it. And it is the craziest time period of your life. And the reality is a lot of women don't have the opportunity to spend 8 hours a day on feeding their children. And that's I remember, in early, you know, post labor days of just thinking like, oh my God, is this real? Like, is this really how,
Yeah. That's basically,
like
so
what
this is
it
my life.
takes?
I do the Metabolic Link and Metabolic Health Initiative.
And
And
you
then
feed your baby.
the majority of my time is spent cooking all meals from scratch
Right.
and feeding him. And to me, it is worth it, but it is a big mental load. I mean,
And
and
it's something that
I'm
not
lucky.
everyone can do,
No,
right? Not
right, for
everyone
sure.
has the resources and the
A
support
thousand
and these,
percent,
yeah. Yeah.
1,000%. And I also understand too, like I come from a place of like I have access to this information and education around
Yes.
nutrition too, which is not readily available to everybody. So I do think it needs to be an education piece for sure, but I also think policy needs to change massively. Like I do think that we need to be restricting uh, honestly, added sugar in children's cereals and things like that, like that should
No.
not be a thing, in my opinion. But everybody has a different opinion around this. But I do think things need to change when it comes to ingredients in our foods, the sugars added to our foods, especially kids foods. Like that
Oh,
shouldn't,
yeah.
in my opinion, be happening. So I think policy needs. I think just as much as education, even maybe before that, because that's going to be a process to educate the public around what is a healthy choice versus not. I just think it's possible, but it's challenging to educate the masses on that level. I think it needs to come from the top down, and like restrictions around certain ingredients and added sugars need to be made to certain foods. That's my opinion though. So I don't know. I feel like we could talk about this paper for a long time, but we only have a little while to be able to talk about this next paper, not to shift gears abruptly, but yeah, great discussion around that paper. I think we could talk a lot more about it. And we do actually have some great episodes around ultra processed foods. Todd Wagner, Dom, you recently had him on. Highly suggest checking that out. It's around Food Fight USA and what they're doing. But let's shift gears now to glioblastoma. This episode is brought to you by Fatty 15. I am so excited to share with you guys an incredible scientific breakthrough that supports our long-term health and wellness. It's called C15, and it's the first essential fatty acid to be discovered in 90 years. It's honestly pretty simple, right? Essential nutrients keep our cells healthy, which then in turn keeps us healthy. Fatty 15 is made from patented, pure, and oxidation resistant C15 powder that's derived from plants. It's vegan friendly, free of flavors, fillers, allergens, or preservatives. And C15 is the only ingredient in Fatty 15, 100% pure. And it works in multiple ways. It repairs age-related damage to cells, protects them from future breakdown, boosts mitochondrial energy output, and activates pathways in the body that help regulate our sleep, our mood, our natural repair mechanisms that support our overall health. Sounds pretty awesome, right? Because it is. And Fatty 15 is on a mission to replenish your C15 levels and restore your long-term health. You can get an additional 15% off their 90-day subscription starter kit by going to fatty15.com/metabolic link and use the code metabolic link at checkout. That's fatty15.com/metabolic link and use the code metabolic link at checkout. And this paper titled Clinical Research Framework Proposal for Ketogenic Metabolic Therapy in Glioblastoma. There's quite a few folks on this paper, including yourself, Dom. So I would love for you to kick this off and give us an overview so we can have a brief discussion around it.
And Angela too, I think, yeah.
Oh, yeah,
A
and
lot of
Angela too.
people
Yeah,
on this
sorry,
paper.
Angela.
Basic, wow.
Sorry, God.
Well,
There's
I
like
mean,
so
we
many
weighed
people on
in.
this paper. Yeah.
Yeah, we weighed in on the, the ketogenic diet and the exogenous ketones and the hyperbaric. I think that's what Angela and I, but and also just the whole paper, which was a massive paper. I think it was approaching like 200 pages if you include the supplementary data. So this was published in BMC Medicine journal. It is open access. The title is Clinical Research Framework Proposal for Ketogenic Metabolic Therapy in Glioblastoma. First author is Thomas Durack. The senior author is Dr. Thomas Seyfried, collaborator and friend of ours. Both are. There are, I believe, 49 authors on this paper. That's neuro-oncologists, basic science researchers, many pioneers in the field. So it was great to be part of this particular article, and this particular review could be 10 podcasts. There's so much in it. So I'm just going to break down, the top things that I think are important to talk about, and then Tomas will kind of lead to this discussion. Shortly, we'll have him on, and we'll get into a deep dive of really the mechanisms here and the implementation, which I know people are tuning in for. So the focus of this particular review was leveraging metabolic vulnerabilities in glioblastoma cells and tumors that patients have. And so the idea then that the metabolic theory of cancer sort of posits that GBM and many types of cancers rely heavily on fermentable fuels like glucose and glutamine. And the idea is to develop a more effective, primarily non-toxic therapeutic approach. And in regards to glioblastoma, we know it's the most aggressive and lethal form of primary brain cancer in adults. Very poor prognosis, and the standard of care generally fails to achieve any meaningful long-term survival outcome. So this is kind of like the prototype cancer that we want to study, because the standard of care simply does not work. And the review kind of highlights the need for novel therapeutic strategies that target unique metabolic demands and sort of the Warburg phenotype that is very prominent in glioblastoma. So we have written over the last 10 years. 10 years ago, we had a review come out called Cancer as a Metabolic Disease, Therapeutic Implications. Uh, and Angela was on that too. And you were deep into your PhD research at the time studying this topic. That really hinged upon this idea that that GBM, if we approach it as a mitochondrial metabolic disease rather than solely as a genetic disorder, I would like to add epigenetic to the metabolic too, because I think that's a big factor, kind of touched upon the last paper. But the Warburg phenotype in GBM creates these opportunities for targeting these pathways. And this is very actionable. And so the actionable way to approach this is with the framework that's presented here with the basic science up front. And then the rationale for it is ketone metabolic therapy. So the ketone metabolic therapy could be thought of as like the base therapy that helps other modalities synergize. And I'm going to take a step beyond that ketone metabolic therapy in and of itself is not going to cure cancer, but it sets the stage for other modalities to work. And we'll also extend it to chemotherapy, radiation, actually surgery too. So ketone metabolic therapy, done with debulking surgery, chemotherapy, radiation is mentioned, and also potentially immune-based therapies like PD-1 inhibitors. So ketone metabolic therapy could potentially be a very effective adjuvant, in that context. And I think that's where the trials are headed. This particular framework goes way beyond what has ever been actually even suggested before and goes into so many different modalities that we'll talk about with Tomas, but provides a document that neuro-oncologists and oncology teams can look through and then create personalized metabolic-based therapies for their patient. And it will be very context dependent upon the patient's health, whether, due to calorie restriction, if the patient's overweight, then you could do like some form of like fasting calorie restriction along with it. So there are different ways to induce and sustain ketone metabolic therapies, intermittent fasting, calorie restriction, but you have dietary approaches to ketone metabolic therapy, and then you have supplemental approaches to ketone metabolic therapy with exogenous ketone supplementation. And then you have pharmacological modalities that can be part of and augment ketone metabolic therapy. That could be something like metformin or an SGLT2 inhibitor, which is like a ketogenic therapy in a drug, right? So bringing down glycolysis to maybe there's a role for GLP-1s too, but that's targeting glucose, but there's also targeting glutamine. So there's a toolbox of drugs that can target glucose and glutamine as part of the ketone metabolic therapy. And with Tomas, we'll go into each one of them, I think, and the pros and the cons of each, because most are like if you take something like 2-deoxyglucose, that has been shown in the world of epilepsy as kind of called as a ketogenic diet in a drug, because by inhibiting glycolysis, then it has an anti-seizure effect. So that has, potential here along with, there are different drugs out there. One is called DON, and that's 6-diazo-5-oxy L-norleucine, I think. It's a mouthful, but it's called DON. And DON will basically is a glutamine inhibitor. There are other ways to lower glutamine. For example, EGCG extract can inhibit glutaminase, and sodium phenylbutyrate can conjugate glutamine, and you eliminate it throughout urine. So there are different ways to target glutamine, and we'll talk about that. But the idea is that KMT, ketone metabolic therapy, can be personalized to the patient. There's dietary approaches, supplemental approaches, pharmacological approaches. It can be flexible. It can be adjusted based upon disease progression and the metabolic response of the patient to the initial implementation of ketone metabolic therapy. And I think that's really This is like the science and the art. The art is like adjusting ketone metabolic therapy and titrating the different modalities to the patient to achieve and maintain what we call the glucose ketone index, which is the millimolar concentration of glucose over ketones. For example, if you have a glucose level of 3 and a blood beta hydroxybutyrate level of 3, which is quite difficult to achieve and sustain, but nonetheless, that would be a glucose ketone index of 1. And we know therapeutically, there's been a paper on preclinical animal models and case reports in humans, and I think maybe some pilot trials to show that a GKI of 1 is very, very therapeutic. So the idea is to do that. Ketone supplementation makes it quite easier, as do some of the drugs out there. And there's a strong rationale for combining the diet and drug relationship, that they synergize together. So there's a strong synergistic effects. There are many, many challenges to the standard of care in regard to toxicity. We think that this will make the standard of care reduce the side effects and also augment oxidative stress therapies, which is a big focus of what we're actually looking at now with hyperbaric oxygen. Ketone metabolic therapy will reduce the cancer cell's ability to make energy through ATP through substrate restriction. So it reduces the overall ATP in the cancer cells, and cancer cells use ATP for growth and proliferation, obviously, but it also reduces the cancer cells' antioxidant capacity. And it does that through different ways. One could be the pentose phosphate pathway, just simply by reducing glutathione. So it makes, in that context, in the context of cancer, this actually makes the cancer cells more vulnerable to modalities that kill cancer cells through an oxidative stress mechanism. So that could be the standard of care, or what we're really interested in is things like hyperbaric oxygen and a toolbox of various drugs that can spike and augment and increase oxidative stress in the context of KMT. So in addition to that, the paper also goes into, and I won't go into the details, but it goes to, the current evidence and the future directions. So there's a huge need for large-scale clinical trials. I can't really say randomized controlled. It would be hard to do an RCT in this context, but large-scale clinical trials will be needed to move this forward. And there's also a huge advantage to other modalities that are talked about, including physical activity, stress management. These things can exercise. So the growing field of exercise oncology, building, maintaining muscle. We've talked before in different podcasts about cancer cachexia, which tends to be problematic in cancer patients because you have age-related sarcopenia, cancer cachexia, and if you take chemotherapy drugs, then you have chemotherapy-induced muscle wasting. So you really need to mitigate the muscle wasting, and exercise is probably the biggest lever. Exercise is metabolic therapy. So that's like an important part of the discussion too. We'll get into with Tomas. He's really into working out and everything. So I don't want to get too more into the weeds because there's so much to talk about in this paper.
When was the last time you needed to go to the doctor, but you pushed it off? I know I've done it a million times. Maybe you made the excuse, I don't know which doctor to go to. I'm too busy to find a good doctor, or maybe it'll just heal on its own. Yeah, been there, done that. And I can tell you that booking an appointment to see a doctor can sometimes feel so daunting, but thanks to Zocdoc, you really don't need to put it off anymore. They literally make it so easy to find and book a doctor that's right for you. Zocdoc is a free app and website that you can search and compare high quality in-network doctors and click to instantly book an appointment. You'll have access to book an appointment with a choice of more than 100,000 doctors across every specialty, and you can filter based on who might take your insurance and who's located nearby. Plus, you can also see whether they're highly rated by verified patients, which who doesn't want to know that other people went to see them and like them, they weren't not so great in terms of bedside manner. And once you find the right doctor, you can then see their actual appointment openings right there on the app, choose a time slot, and instantly book. I use it, and I think you should really check it out. Stop putting off going to the doctor. Just go once and for all and go to Zocdoc.com/metabolic link to find and instantly book a top-rated doctor today. That's Zocdoc.com/metabolic link. Zocdoc.com/metabolic link. Check them out and stop putting it off. And I know you'll enjoy the app.
But I am super excited that this got published. It's been a work in progress for 3 years now, I think, and it was the longest review I've ever seen written. And I was like, there's no way. But this is open access, so people can access this now. Again, the title of this paper is Clinical Framework for Ketogenic Metabolic Therapies in Glioblastoma. It's in BMC medicine, and you can access this open access. And I would encourage people to also access the supplementary data because there's huge amounts of data in the supplementary files that you can click on the links, and it's all free, open access. And again, I think this paper here, I think, is the biggest publication so far to move the needle on advancing the science and the application really of ketone metabolic therapy. And it references, our previous work, and it's been just great to be part of this team. So of people to bring this out. So it's definitely it was a team effort. It was a very collaborative effort to bring this out, and it's amazing to see it in print.
Yeah, hats
Yeah.
off. Hats off to all of you, including the two of you, on a pretty incredible paper. Angela, what were you going to say?
Oh, yeah, I was just gonna say, yeah, it is really more than anything just an outstanding resource. It's written kind of in with the concept of like this is how you can put together if you want to study this further clinically, this is how we need to do it, which it sounds kind of basic in that sense, but it's so important for something like this. That is an issue that plagues our field, is that diet studies, and in particular ketogenic diet and cancer, where there's a lot of research looking at combining ketogenic diet or ketone metabolic therapy with other complementary and standard of care therapies, and it creates a whole lot of interesting data, but not a lot is standardized between studies, and so it's really hard to kind of conceptualize what we're seeing. So I love the idea of this big framework that kind of says like, here's an outline, here's some metrics, here's how you can set up a study properly. And then it's so obviously from the research perspective, I think it's going to be hugely helpful in that regard, but I think also it's going to be a really valuable tool for patients and their oncologists who might be interested in utilizing ketogenic metabolic therapy in their care, and just being able to have this one very comprehensive, very well referenced publication that they can go to and have a plan and a backup plan and understand, okay, this is how we change, based on what we're seeing, how the patient's responding. So I'm really proud of that in that regard, that it's just a resource that's been needed for a long time, and is finally available.
Yeah,
Yeah,
and
you mentioned references. There's 750 references in this paper. That's the most I've ever seen in any
Yeah.
review. And yeah, I'll say that I get contacted by oncology teams
Yes.
every day, like today, for example, a couple, and they said their patients will find it very hard to implement a dietary therapy.
Yeah.
So they're in luck though, because this review really delves into ways that you can circumvent even. I mean,
Hmm.
Angela, you did a study just on ketone supplementation with a standard
Yeah.
diet, right?
Yeah.
So I
Hmm.
referenced that. So
Yeah.
you could potentially put together ketone metabolic therapy with glycolytic inhibitors,
Hmm.
SGLT2 inhibitors, 2-deoxyglucose, ketone supplementation, and that could actually induce and potentially just, sustain,
Hmm.
you know, a GKI.
Yeah.
Even without a dietary intervention. We're not advocating for that. We strongly advocate for a dietary approach to be the foundation, but there's a rationale for even
Yeah.
circumventing diet,
And
which
just meeting
we're
people
getting
where
asked that question a lot.
yeah, what they're able to do or willing to do,
Yeah. Mhm.
and giving people choices, because, patient autonomy and informed, shared decision making with your healthcare provider is really important. So having the information available and accessible so that you can choose, what makes sense for you, I think is huge.
Yeah, this resource is something I wish I had in 2016, 17 when working with actually Jethro, who I see is also on the paper, which is
Mhm.
pretty cool.
Yep.
We worked with, gosh, almost 20 of his glioblastoma. Well, they had a few different types of cancer specifically, but glioblastoma patients were in that group. And it was, we were navigating unmarked territory at that time. But I will say the effects of the diet that we saw were just unbelievable. I mean, these are patients where standard of care, unfortunately, you don't typically see improvement with these patients. It's typically like a pretty fairly quick decline. And many of these patients that we worked with alongside LJ Amaral as well, some, were suffering from aphasia, could then read again. Others had lost the ability to walk and started to regain that ability, and just things that you don't see uh, in cancer patients, in brain cancer patients specifically, was pretty profound. And so, having something like this as a resource is just so valuable because I will say it's really challenging when you're working with different patients who have different lives, different influences, different wants in terms of, what they're willing to do exercise wise and, all the things, right? Or what other medications they're on. That can be incredibly challenging to navigate, especially, when you're trying to hit a specific GKI, like you were talking about, Dom. That can be so difficult to do when you're on something like
Yep.
dexamethasone or whatever the case may be.
Yes.
So,
Yep.
or just dealing with the stress of a terrible diagnosis like glioblastoma. I mean, that variable in and of itself is so hard to navigate. Like stress reduction has to be a huge part of this as well. So
Mhm.
having something like this for, whether it's practitioners, other people wanting to study this, as you mentioned, Angela, having, some sort of standardization is so key, I think, in moving the needle
Mhm.
in something that needs this kind of therapy in the mix because there really aren't great outcomes already with, current standard of care, unfortunately, maybe extends your life by
Mhm.
months. And, most people dealing with GBM, you're looking at maybe 2 years if you're lucky. So
Yep.
this is hats off to everybody involved in this paper. We'll be sure to link all of these papers that we've talked about. I don't know if you guys want to mention anything as before we go regarding both, but this was a great discussion, guys. A lot of fun to dig
Yeah.
into both, and appreciate the conversation and appreciate you listening or watching the Metabolic Link. And we would again love to hear what you think about our journal clubs, if they're helpful, if we can make them better in any way. This is your podcast, and we want to basically continue to spread the science around metabolic health and therapy in the best way that we can. And if you want to check out, as I mentioned, private exclusive episodes of the podcast that are ad-free, you can head on over to our membership platform, the Metabolic Initiative, at membership.metabolicinitiative.com. And we have incredible experts that are going to be coming up in live Q&As here soon. So you'll definitely want to check out the platform if you are interested in our robust library of metabolic health and therapy videos, podcast episodes, ebooks, you name it. And then you get to connect one-on-one with world-class experts. So yeah, but thanks guys for the great discussion as always. And I'm really looking forward to the next one.
Me too.
Thank
Thanks.
you. Thanks for having us.
Thank you. All right. Thank you all for watching. We'll see you soon.
All right. See ya. Do you love learning about metabolic health? So do we. It's why we created the Metabolic Initiative, an online educational platform providing evidence-based education on metabolic health and therapies for healthcare professionals and the general public. By joining the Metabolic Initiative, you'll gain access to hundreds of expert lectures, interviews, panel discussions, and even private episodes of the Metabolic Link. CMEs are available. Go to metabolicinitiative.com to get started. And as always, thank you for listening to the Metabolic Link.